So guys, welcome to part 2 of our cut on approach to a patient with jaundice, clinical approach of course. So now we have a patient that has got jaundice. So please, before you come to this part, which is part 2, please make sure that you go through part 1 first, and also go through an approach to LFTs, also go through an approach to an FBC. It's going to be very helpful. So now we have this patient that we have seen that has got jaundice. At this point, we are suspecting that, okay, our patient might be having cholestatic jaundice. Even if the patient has got cholestatic jaundice, you still have got to do tests that will confirm if the patient has hemolysis or not, even if it's obstruction. We can't say the patient has got obstructive jaundice, so let's just only focus on tests that confirm obstructive jaundice. We are still going to do tests that will also check if the patient might be having any form of hemolysis. So so we're going to do bloods here, and then this side is going to be imaging. When it comes to blood, yes, FBC is our friend, a very good friend of ours. An FBC can tell us a lot when you know how to interpret it to the core. So what we're going to check on the FBC, we're going to check the white cell count. We want to know if we have got, and it would also help to do the differential count. Remember, you get a lot of lymphocytes when you've got viral infections. So do the diff as well, FBC plus diff, because remember there are viruses that do cause hepatitis, and obviously since a viral infection, then you might have lymphocytosis. So a high white cell count. We might have a white cell count and also neutrophils, which means now we also have a bacterial infection that is happening, especially in the case where we have cholangitis. So we might have neutrophils being elevated and also lymphocytes being elevated. So that's the white cell part. And remember, a white cell count for infection is around 14, 15, 16, 17, 18, 19, maybe up to 30 in severe cases. But the minute it reaches 80, 90, 100, chances are there's a malignancy that is happening. It's not a white cell count that is suggestive of infection, like I explained in that approach to an FBC. So white cell count. Then the next thing is the HB. When you have a jaundice, the patient, you want to know, are they hemolyzing? Because if they are hemolyzing, then you should have some kind of anemia. Because if the red cells are being broken down, then you should have some kind of anemia. So white cell count, FBC. So this one will help us to check if there's infection, be it viral or bacterial ascending cholangitis. Okay, that's the FBC. Obviously, we will do the LFT as well. LFT. When you do an LFT, remember, the enzymes of the liver, like AST, ALT, those are not really, they don't tell us about the synthetic function of the liver. When you want to check the synthetic function of the liver, you need to do albumin, INR, PT. So when you have a liver that is failing, you start having a drop in this. When you are getting into liver failure, you start having and then you also get those persistent hypoglycemias. So that patient has got acute liver failure, that patient, when they've got jaundice and then they've got deranged, a very low albumin and a very high INR. The enzymes, when you look at them, please go and watch a video on approach to LFT, because I'm not going to go into detail in this video. So the enzymes, you can check if you are dealing with. So when you look at the enzymes, you can, depending which ones are elevated, you can suspect that you've got a hepatic problem. That is, if you've got an increased ALT and AST, or you can suspect you've got an obstruction problem if you've got an elevated ALP and GGT. This is AST and ALT. So then you can decide, oh, okay, I've got a patient with jaundice and my patient has got obstruction. This will push you to the imaging. This patient needs an ultrasound, because you want to know where is the obstruction in the biliary tree. Is it inside? First of all, is it inside the liver itself? Because you can have obstruction inside the liver itself, or is it an obstruction in the biliary tree? So you can do the ultrasound. So with the when you've got this, so this patient basically becomes a surgical patient, especially if the obstruction is in the biliary tree. But if the obstruction is in the liver itself, you can have the physicians or the internists working with the surgery department together. So, but when you've got this high, then that's purely a medical patient. It's a medical patient. So when you, so this is the, so this is the first blood, FBC, the second blood, LFT, including these guys. I know most of the times when you talk about an LFT, we're just talking about the enzymes, but true LFTs is albumin and INR. So the next thing to do now is to say, let's say now the patient doesn't have any of this, but when you take these bloods, you should just take all of them so that you don't just delay, you don't delay diagnosis and not delay patient care. Okay, before I move on, once you discover that your patient has got obstructive jaundice, you need to make sure that they don't have acute cholangitis. So what do you look at? Then, like I mentioned earlier, you check, clinically check how they are. Do they look toxic? Check their pulse, check their temperature, check their BP, because they might be going into septic shock, and check their white cell count, check their CRP. Once they have obstructive jaundice and then they've got this, that's cholangitis. Okay, so the next thing we want to see now, are we having jaundice because of a prehepatic problem, like a hemolysis problem? If you do, so the bloods that you want to do, obviously by the time you were doing your LFT, you would have gotten your bilirubin, the total bilirubin. Now, if your patient has got an increased unconjugated, let me do it this way. Test that you can do to check for hemolysis. There are a lot of them. Obviously, we said HB low. Number 2, increased unconjugated. Unconjugated. A low heptoglobin. So what is so if you have hemolysis, you expect to have a low HB, anemia, number 1. Number 2, we expect to have a very high unconjugated bilirubin as compared to the conjugated. And then you also expect to have a low heptoglobin. What's a heptoglobin? A heptoglobin is a protein that is synthesized and secreted by the liver. And its main job is to clear free-floating hemoglobin. So if you have got a lot of hemoglobin because you are hemolyzing, then the heptoglobin is gonna be used up trying to clear the free-floating hemoglobin, such that so you're gonna get to a point whereby the rate at which the heptoglobin is used is much more higher than the rate at which the liver is replacing it. So now you get a low heptoglobin. Let me use a different color there. So another test that you can do is LDH. LDH, when it's very high, it does, as much as LDH is secreted by lactate dehydrogenase. LDH is lactate dehydrogenase. It's an enzyme that is found in many cells, and it's also found in red cells. So if you have got hemolysis, you've got anemia, you've got unconjugated bilirubin and a very high LDH, it means those red cells which are being broken down, they are releasing a lot of LDH. So it's a test to diagnose hemolysis. So if on your patient all of these are fine, there's no obstruction, these are okay, these guys are okay as well. Remember, if these guys are not fine, then if AST, ALT are abnormal, then chances are you've got some kind of liver injury. It can be viral hepatitis, drug-induced hepatitis, herbal medication, anything. Because when you've got a high AST and high ALT, so it's purely a liver problem. That's why you've got the jaundice. But if those are fine or just mildly elevated, but you've got a predominant increased ALP and GGT, then it means you've got a post-obstructive, a post-hepatic jaundice. But if these and these are fine, but you've got a problem here, it means now your problem is a hemolysis problem. So it's a prehepatic problem. One other thing that can also be done is peripheral smear. Peripheral smear. And making sure that they do a malaria smear. When you do a peripheral smear, you can diagnose a lot of so basically peripheral smear looks at the morphology of the cells. How are they looking, these cells? So you can diagnose some malignancy, or you can suspect some malignancies there. You can suspect some hemolytic anemias, because many hemolytic anemias have got abnormal morphology. Their cells have got abnormal, their red cells have got abnormal morphology. So this guy will tell you about malaria. Let me see if I'm leaving anything. So when you've got a patient that has got a jaundice, it will never be a problem. You will never do any harm if you send this patient for an abdominal ultrasound to look for a liver. What is happening inside the liver? Is the liver draining clearly? Is there an obstruction in the liver? How is the spleen? Is it, because there are some spleens that are not palpable but they are still enlarged. So, and then now when you've got all of these, then this becomes hematology problem or oncology problem, or some physicians can manage these patients. These ones, surgeons, these ones, physicians. I'm not sure if I'm leaving anything. So we are going to meet on part 3 of this, where now we're going to talk about the causes of jaundice. This was a clinical approach now. What are the things that you need to look at, and what investigations that you would want to do, and all of that, and all of that, and all of that. So definitely when you are working in surgery, they might say, okay, ultrasound is sufficient, or they might say, okay, let's do an MRCP, some even ERCP, some will say, okay, let's do a CT. So, but it's their own. I think I've covered biliary disorders, but I haven't covered a lot of malignancies like cholangiocarcinomas, tumors there. It can be, the cause can be. So let's talk about the causes of jaundice on part 3 of this. If I'm forgetting any test that is relevant, please comment and let me know. Thank you.